Good morning. My name is Saran Ephraim, and I am a member of the Georgia HPV Work Group, which is a subgroup of the Georgia Cancer Control Consortium. The HPV Work Group is comprised of members representing universities, medical health systems, including hospitals, community cancer coalitions, the American Cancer Society, the Georgia Department of Public Health, and pharmaceutical partners. Today's offering is the third and final in a three-part series titled HPV Vaccinations Getting Back on Track. Today we will be discussing the data. We have immunization data, so now what? To obtain CE credits for today's presentation, you must be in attendance for the full duration of the presentation. You need to also submit your evaluation by December 3rd, and you will receive a certificate of completion by December 4th. And there are no conflicts of interest that exist for any of our presenters today. Just a few housekeeping matters. So all phones and videos are muted for participants. So if you have any questions or if you have any technical issues, please let us know by using the chat box. As a reminder, for all participants who are interested in receiving CE credits, you must be in attendance for the entire duration of the activity. So our first presenter today is Lori Politano. Lori Politano is a registered nurse and has been an RN for almost 10 years. Lori has worked in several areas, including medical surgery, neuro, telemetry, ER, infusion clinics, and home health. Lori has worked with MedLink Georgia for 2 years, and she currently serves as the clinical coordinator, along with her newer role as quality assurance and quality improvement manager. Please welcome Lori.
Thank you, Saran, for the introduction. I'm going to try to get my camera on now because it just went away on me. So I apologize. Okay. Oh, there it is. I'm sorry. I'm having difficulties this morning. Okay, so for whatever reason, Saran, it is not letting me show my camera now. I don't know what happened. So if I can figure it out later, I will go ahead and share my screen. Thank you for the introduction. Like Saran said, I am Lori with MedLink Georgia. We have partnered with the American Cancer Society for improving our completed HPV vaccination rates. MedLink Georgia, we are located in North Georgia. We are a federally qualified health center. We have 16 medical sites, which include 2 pediatric centers and 1 women's health center. We have 1 dental office, 4 pharmacies that are attached to our medical sites, behavioral health, and then rehab, which is our outpatient physical therapy and occupational therapy. We also do have, not listed on this slide, a diabetes program, which is a certified diabetes educator and a dietitian that we offer. So our goal that we came up with when discussing with American Cancer Society and along with our pediatricians and medical assistants at our Colbert location was we wanted to improve our completion rate of HPV vaccination to 50% for adolescents ages 11 through 12 years old, specifically at our Colbert pediatric location. So how did we come to that goal? Like I said, we did have a roundtable discussion with our pediatricians and medical assistants, along with American Cancer Society, where we discussed what our current process of HPV vaccinations were. So when discussing, most of our vaccines are encouraged at their annual wellness visit. And then at the beginning of the day, we have a huddle discussion with our MAs and providers, have a huddle discussion, and they go through all the patients that day, what they need. Specifically for our HPV patients, we print the grits out and kind of have a game plan of what we're going to let the parents know they need. Our MAs has the first interaction with the patients and their families. So they start that conversation of what vaccines that they're going to be needing at the visit today. So specifically related to HPV, we do have HPV brochures in our triage room and in the patient's rooms. That way parents can read about it while they're waiting to see the pediatrician. We also encourage the patients to ask the providers any questions. So when the provider comes in, of course, they discuss the HPV vaccination with them, and then our MA will administer it. And then at the end of the visit is when we will try to get them to schedule for their second shot in the series. Some barriers that we had were parents felt 9 years old was maybe too young for them to start talking about HPV vaccines. They maybe think that it's for girls only, that their sons don't need it. Some of them even felt that it was more of like a birth control method, that they were giving it okay for their child to be sexually active so young. So in doing so, we decided that the 11 and 12-year-old age group was the most appropriate because we could start talking about it at the 9 and 10-year-olds, really pushing it to at 11 and 12-year-olds so they would only need 2 shots in the series instead of having to have 3 shots when they were older. When we first did our data, we have 39% of patients completed that first dose in our 11 to 12-year-old range. And then 17% of our 11-year, 12-year-olds for the Colbert location was for the second dose was 17%. So one of the things is, how are we going to roll out this HPV project? Staff engagement, our data from our EMR, which we use Athena, our EMR quality measure reminders that we have, and then a patient reminder. So staff engagement, we did a project kickoff during a morning huddle. You know, we presented the HPV, we had some donuts, we had a poster that we displayed that shows what percentages we were at. We even broke it down to male to female. And surprisingly, our male and females completion rate for first dose and second is pretty close. And then that is being updated throughout the process. We started this back with HPV back in July, so it will be ending in December. Our data, like I said, we get it from Athena, and kind of already discussed it. We had a list of who already completed it, who needed a second dose, and then who hasn't received that vaccine at all. And from this, we went ahead and we started calling patients, getting them in to get them scheduled. We do have a section in our EMRs for quality measure reminders. So we'll actually come up and say, patient is due for HPV vaccination, and that will show up on every visit until they complete it. And then of course, patient reminders, of course, scheduling those appointments for the second shot before they leave their appointment. So they're already on the schedule and they don't have to do it. Calling patients to schedule for their vaccinations and annual wellness visits to get them back in. And then the next thing we're going to do is on those patients that we've called and they're not returning our calls, they're not setting an appointment, we are going to send out a little mailer to them just as another form of communication to them. So some barriers that we have already come across throughout our project, of course, COVID, nobody wanting to come into the office, so they're trying to stay out unless they absolutely have to come in. We've had quite a few parents just refusing the vaccine. So we're still doing a lot of education, even if parents are refusing it every time they come in. That is something we still discuss. We're not giving up on them. And we give them the brochures as well as when they're in here. So they'll have that. When we're calling patients, like I said, we're not able to reach them. They're not returning our calls. We're leaving voicemails. One of the other things that we thought we might be able to utilize was our GRITS data from a report in GRITS. However, what we saw is it didn't do it on one document. You had to scroll and you had to print out like hundreds of papers. So it was just easier for us to use our EMR data. And then of course we can compare it to the GRITS data if we need to. This was a lot for just one person to keep up with, as we don't have someone dedicated specifically, that's all they do all day. So we are bringing on more help from our quality team to help us with this, and just even getting the MAs involved and for their patients calling them. And that is the end of my presentation.
Thank you so much, Lori. We have a quick poll that we would like to ask. So you should see the poll on your screen. So the question is, which of the following was not used to improve HPV vaccination rates at Medlink Coburn? So I'm gonna give you a few seconds to go ahead and submit your answers. All right, the votes are coming in. Okay. So the question is, which of the following was not used to improve HPV vaccination rates at Medlink Coburn? So here are the results. So the options or the answers were A, patient reminders, B, EMR quality measure reminders, C, not scheduling the second HPV vaccination appointment while the patient was in the clinic, D, data from the EMR, and E, staff engagement. So the correct answer was C. Medlink made sure to schedule the second HPV vaccine appointment while the patient was in the clinic. All right. Our next presenter is Dr. Becky White. Dr. White has lived and practiced in South Carolina for the past 12 years. She graduated from the University of Iowa Medical School in 2001. She is part of the South Carolina Immunization Task Force and was thrilled to attend the first Southeast Regional Immunization meeting in Birmingham, Alabama. She works at a small pediatric family medicine and behavioral health practice in Little Mountain, South Carolina, and is currently the pediatric division director for Cooperative Health Center. Thank you for joining us today, Dr. White.
Thank you, Saran. So I'm also from FQHC, just like Lori is. We are in South Carolina. I've been here since 2008. So just to show you how much things have changed, these are my kiddos from 2008, the first year that we moved here. And also to remind you that, yes, we're talking about data today, but this data corresponds to real people. So my kids at this age, of course, I wasn't thinking about anything besides their baby shots. Of course, I had already been giving Gardasil in my practice in Iowa, but doing a huge quality improvement project really was not on my radar. Until the American Cancer Society approached us and said, you know, we're providing some grants. We would like to partner with you. So they had already looked at the data for South Carolina, which I'm sure were very, very similar to Georgia, where, you know, in the Southeast, the Southern region, where new things are slow to be adopted. And we also have a large population that don't have health care for whatever reason. So our statistics were pretty scary. Back in 2012 to 2016, over half of women diagnosed with cervical cancer in South Carolina had advanced stages, and only 66% of them were living 5 years after their diagnosis. So really, really scary data there. As I mentioned, I am the Pediatric Division Director for Cooperative Health. We serve 4 different counties. In South Carolina, we're the largest FQHC, and over 75% of our patients are at or below poverty level. Back in 2015, when we started this project, we had 18 primary care sites, including family medicine, pediatrics, walk-ins, and OB services. And at that time, we were seeing approximately 50,000 people a year. So when the American Cancer Society said, we're really interested, we looked at our data. And unfortunately, it wasn't really great. In 2014, across all of our pediatric sites, which was only 6 sites at the time, we now have more, patients getting their first dose was only about 26% of our population. We decided that 6 sites was just way too many to try to do this project with. So they decided to concentrate on just 2 of our sites. So we had our rural site, which I was at, Pediatrics of Newberry, which is a town of about 13,000. And then we had Sterling Sharp, who was our city site, and they're located right in the middle of Columbia, which of course is one of the biggest cities in our state. When we looked at just those 2 sites, first dose was still 26%. Getting that second dose dropped to 16%. And the third dose, which at that time, everybody had to do 3 doses, was only 19%. We had huge challenges. Number one, buy-in. A lot of our providers just looked at our population health people and said, that's not right. I'm sure none of you have ever heard a doctor say, oh no, I'm much better than that. Yeah, so that was an issue, getting our providers engaged and actually believing that our data was real. Time, at the time we were using an electronic health record that was not linked to our state immunization registry. So our nursing staff were actually having to double enter all vaccines. So first into our system and then into the immunization registry for the state. And vice versa, if a new patient came to us from another practice, we had to pull the record from the immunization registry and enter it separately into our electronic medical record, which was a huge time suck for us, actually. Education, we actually had some providers that didn't believe in using the vaccine. It was still highly perceived as the sex vaccine. You give it, you're given permission to have sex. As Lori mentioned, some people actually thought it was a form of birth control, which was totally not true. But we had to not only educate our providers and our patients, but also our staff, because as Lori also mentioned, the MA is the first person that encounters our patients in the back. It's often who sometimes, unfortunately, they spend the most time talking to. And if the MA doesn't recommend it, the patient isn't necessarily going to recommend it either. No shows, of course, with our patient population, they don't have transportation. There isn't good free transportation, especially at our rural sites. In 2013, only Tdap was mandated by our state. It still is the only one. We just had another meeting and we're told since it's an election year, meningitis mandation is off the table. Staff turnover, again, educating and re-educating people. At the time, we were only giving vaccines at well visits, really. We were missing all those opportunities at the sick visits. And we also, at both Sterling Sharp and Pediatrics of Newberry, had large groups of vaccine decliners. Unfortunately, we had gotten known on the internet as this is a site you can go to, if you don't believe in vaccines. So in June of 2015, the American Cancer Society representatives attended our pediatric division meeting. They formed an implementation team. They gave each of us a huge tote of all these fabulous resources. We had posters, pins, cards, information sheets, note cards, recommendations for, Wear Jean Friday. Friday's going to be our HPV vaccine day. We're going to have special clinics, and we're going to set our goals. I would like to say that it was met with full on, yes, we're going to do this. I was actually the one who raised my hand and said, why on earth did you pick my site? This is not going to work very well. Luckily, I was proven wrong. In July, what really sparked it off for the providers was the grant paid for us to do an EKIP. An EKIP is a quality improvement, not really a grant, but a study program sponsored by the AAP that gave us the potential to earn up to 25 hours of CMEs, which is very, very high on providers' list of things we got to do, as well as Part 4 maintenance of certification credit. So for those of you who aren't physicians, not only do we have to prove that we're continuing to learn, but Part 4 of our boards is you have to do a quality improvement project. So them being able to come to us and say, hey, we're paying for you to do this, and you're going to get this part of your boards taken care of in one fell swoop, was a huge deal. Of course, it took what seemed like forever to get everybody organized. The implementation team visited offices. They went to the office meetings. We finally got all the data pulled out of our system to send birthday cards to all of our soon-to-be 11-year-olds saying, hey, happy 11th birthday. It's time for some shots. We also mailed vaccine reminders to all of those that had started the series and hadn't finished it. And also each office got a nice whiteboard to actually write down what dose was given for what provider, so that we actually fostered some competitive spirit, not only between offices, but between providers. Who can give the most amount of doses in a month. Some of the barriers were really procedural and organizational. I mentioned our medical record didn't communicate with our state registry. The April following the start of this grant in 2016, we actually switched to Athena as well, which Lori said that her system is on as well. And it does make it a lot easier to look at each patient's immunizations or their quality tab and see what is missing, what they need. We also started something that was really huge, which was doing that huddle in the morning, having either the provider or the nurse or the MA go through the entire schedule and see who needed what, whether they were coming in for the sick visit or the well visit, so we could get these kids caught up on everything. We also gave each office a list of the patients that needed to either start or complete the series, so that in their free time they could sit down and work the list, calling these patients. In October of 2016, there was the FDA approval for the 2-dose, which of course messed up all of our data, but also made it easier for everybody to complete the series, unless of course they started it after age 15, in which case still the 3 doses is recommended. We actually, by the time December rolled around, we're doing so great on our goals that our pediatric division director at the time said, you know what, we're just going to have a meeting sharing best practices, and we're going to roll this out to the rest of our sites. Our goal was to hit at least 50% at the 2 sites. And we were already at the 30 to 40% improvement for those sites. We had already blown away our goal, actually, just with those practices. So we had the big meeting and we shared what worked. One of the suggestions was, as Lori mentioned as well, starting that talk at that 9-10-year-old age. And if they weren't ready to give it at that point, in order to get less shots at the next visit, at least that's in the back of mom and dad's mind. We can give them the research. They have time to sit and discuss it with the rest of the family, go online and Google our favorite word, what they wanted to do. We also discussed that putting posters up in the room really worked for us because that's a captive audience. I actually had a few patients that would point to the poster and say, what's that? I don't want to get that. When can I have that shot? And we had it in both Spanish and English. So we also had some families from both backgrounds that would look at it and go, okay, I need that. Things that really didn't work, we found out that handing cards out at the front desk that says, I'm getting my first dose of HPV today. We found a lot of the cards in the waiting room, stuffed under the chairs, thrown in the trash. We found that educating the staff really, really worked, because then they went to their families and said, we can prevent cancer. Remember all those, abnormal pap smears Aunt Susie had to go through? We now have something that can prevent that. So that really, really helped, just getting that word out in the community about this is a good thing. It's not a sex thing. It's an anti-cancer thing. By June of 2017, our grant finished. We had survived 2 years of doing our quality improvement project. So we all cheered and patted ourselves on the back and looked back at our data. We had actually increased our first dose take up from that 26% to 68% at our 2 sites. Second dose didn't increase quite as much, but 22%. And then, those that still needed that third dose, at least 10% of them got that as well. For all of our sites, even though they started later than our 2, we moved the needle up to 66%, with that second dose being 27% and our third dose 13%. So we were just blown away. And really, so here's the reminder that these are my kids now, 12 years later. Now definitely worried about them being teenagers and making sure that they've gotten everything that they need before they enter adult life. And we're continuing to maintain our rates at all of our sites. We're still organizing our data. Athena's really great user-friendly chart-wise, but not so much polling report-wise. So we actually just added on a new data management system where we can pull, how many kids at this practice with this Medicaid still need their HPV. And then we can take that to that Medicaid company and say, what can we do to improve this? Can you send out reminders? Can you help us send out reminders? some of the Medicaid companies here in South Carolina actually started giving free diapers, or there was a $10 Target card they could get if they sent in a paper signed by their providers saying they got their well visit or they got their immunizations. So that really has helped bring our patients back in despite COVID. Again, starting at those early ages so parents have time to process. And I've had parents that say, you know what, I had a lot of abnormal PAPs. I never want my child to go through that. Give them their shot now at age 9. And same thing with boys. Now that the recommendation also includes head and neck oropharyngeal cancers for boys. You know, when they say, well, boys don't have a cervix, they can still get anal cancer, penile cancer, and genital warts from the HPV virus. And the vaccine prevents that. So that's another selling point for our male patients. And again, doing those visual aids, showing the picture of that terrible looking cervix or the warts, or even just the poster saying, hey, has your child had this series of vaccines yet, really, really helps. So that's my talk for today. Always keep in the back of your mind that these aren't just numbers. These are kiddos that we want to never have to go through this. And feel free to send in the chat box. There's a question now. So we do now have a statewide, well, we had a statewide system before. It just didn't pull into our immunization record. Now that we have Athena, it does pull in, and actually South Carolina just switched to a new immunization record for the entire state called Simon, which is supposed to have even better connectivity with all the myriad of electronic health records that are out there. So that saving time has really been a blessing.
Thank you so much, Dr. White, for your talk and presentation. This was wonderful. We have our next poll question that I will be sharing on your screen. Okay. This one is asking, what has contributed to cooperative health maintaining their HPV vaccination rates? Please choose all the correct answers, or the correct answer. So it's A, organized data, B, start at age 13, C, bundle vaccines, D, provide visual aid, or E, A, C, and D, which would be organized data, bundle vaccines, and provide visual aids. I'm going to give you a few more seconds to go ahead and complete this. Okay, thank you for all those who have submitted answers. I'm going to share the results, and you all have been paying attention because you got it right. So thank you for participating. The correct answer was E, that they had organized data, they bundled vaccines, and they provided visual aids. Thank you. So at this time, we will take any questions that you all have for either Dr. White or Lori. We've got one in the chat that was answered. If you would like to ask questions, you can put it in the chat box. While we wait, I did have a question for Dr. White. If you could go back and do something differently with regards to this quality improvement project you embarked upon, what would be something that you would change?
Things I would change, we probably could have rolled it out to all of the sites and potentially had even more best practices to share because each site is a little bit different. I think also it would have really helped to have more people involved. We did pick a physician champion and a nurse champion at each site. but they weren't necessarily the ones that had the most amount of time to spend pulling reports and going through all these lists. Initially, it was thought that each office could sign all of the birthday cards. The implementation team was really disappointed to find out we were not going to sign 2,000 different birthday cards for our patients. So just having a little extra manpower would have helped too.
Excellent. There's a question that came in the chat box that asks, how often did your team meet to review your progress?
So each office met and went over the numbers at their office meeting, which was once a month. Cooperative wide, our pediatric division meetings are approximately every 3 months. So we would have a little update at that point as well.
Excellent, thank you. This question is for both you and Lori. What kinds of things help to get the buy-in for providers? Like you mentioned, some providers felt like we're not that bad, we're probably doing better, the data's wrong. So what types of things could help improve buy-in from your office and the practice members?
Definitely looking, making sure the data is clean. We still, even on other quality improvement projects, get pushed back about, well, that patient only visited our office once. There was no way we were going to meet that measure because we were never going to see them again. So making sure that patients that haven't been seen in the last 3 years are listed as an active patient helps. Again, that CME and that competitive spirit between providers really helped light a fire under people.
Lori, do you have anything to add?
Got it to work this time for video. Not really. I mean, just, our providers knew that our numbers were pretty low, so they were just excited that we were going to implement something to help improve our numbers. And just to have a little bit more support from admin, so to speak, and just something else to focus on HPV specifically.
And just one last question to both of you. So really the data obviously played a critical role in helping to get the buy-in, but can you speak to the value of having that data just throughout the process to see where things are, and if you had to adjust throughout the quality improvement process because of the information you got from data?
Go ahead, Lori.
Okay. I just think, it was nice to have, it's nice to have that data to see your improvement, that we are making a difference, and that, we're not just doing this and not seeing any effect from it, that we're just seeing our goals be met.
It really helped having that whiteboard up in the office where everybody could see it. Because at our office meeting, we would put our new number or percentage and then come up with, so that really just kept moving the needle for us.
Well, thank you so very much to you both for presenting and sharing such valuable information today. We have a quick video that we wanted to share with you all at this time.
A big part of the end of cancer is the end of the fear of cancer.
When a diagnosis is met with, okay, this is serious, but we know how to take care of it.
Cancer is such an integral part of life that the only thing we can actually do is call it the end of death by cancer.
I look for a day in which
there is less suffering from cancer. If we can't cure it, to at least turn it into a chronic disease.
I think the key really will be with cancer prevention.
Early stage cancers are by far easier to treat.
So hopefully we're pushing off the onset of cancer, catching it early, and then once it's caught, having therapies that are specific to that patient.
So if we are introducing new ways to detect cancer at a very early stage, we can turn a cancer diagnosis from a death sentence into a routine procedure to remove that cancer.
Scientists are very optimistic because we've seen, even in my lifetime, things that we never thought could be accomplished.
The end of cancer is here for many cancers, and the future will be the same. 50 years from now, we'll wake up and things will be a lot better, but it's not going to happen all at once.
So I'm preaching to the choir here about cancer prevention, and specifically with the HPV vaccine, that it is a method to prevent 6 different types of cancers. So this is something that you want to communicate to your patients in the office. It's hard to see, you know, in pediatric offices, it's hard for the parent to see the benefit of vaccines because oftentimes the not vaccinating doesn't show up until much later in life. So it's critical for us to make sure we communicate that to the patients and to the parents and the guardians of these individuals, that vaccination with HPV vaccine is cancer prevention. We also wanted to share a quick resource about the cancers that are associated with HPV virus, or the human papillomavirus. And you can get that resource here at this link, as well as a Spanish version as well. So it is my honor to introduce our next speaker. Kevin Ranshaw lives in Marietta, Georgia with his wife, Jennifer. They're about to celebrate 32 years this month. So congratulations to them. Along with their 18-year-old daughter, Isabel, and 17-year-old son, Kirk, as well as his mother, Betty. Kevin is a sales marketing vice president for Folletta Higher Education Group. He is very active in the local arts community and is current president of Mountain View Arts Alliance and former artistic director at Center Stage North Theater. Kevin is a writer, director, actor, and occasional set designer. Kevin was diagnosed with cancer related to HPV-16 in April of 2019. Neck dissection and lymph nodes removed on the right side, followed by TORS procedures and 30 RADs. Completed those treatments back in October of 2019, and to date, there are no signs of reoccurrence and the healing is continuing. Kevin, thank you so much for joining us today. I'm going to turn it over to you.
Thank you so much for having me, and thanks to all the healthcare folks on this webinar today and for the work you're doing. And I really appreciate the invitation to share my story, my journey, and hopefully maybe it'll help make a difference when you're talking to a family that's in your offices. Yes, indeed, I'm celebrating 30 years of marriage. My wife and I, Jennifer, met in college. We've had some amazing experiences in our life, but few the fear, the uncertainty, the loss of control that comes with a cancer diagnosis. Before that, I was a patient. For most of my life, I would go, I always have my annual physical, dentist twice a year. I go to the dermatologist, that really is. Every other year I go to the eye doctor, rarely sick visits. I always get my flu shot, moderate exercise, run a couple of 5Ks in my life. My blood pressure is always like 120 over 70 something. Boring, absolutely boring. I didn't take any maintenance medications or anything at 54 years old, feeling pretty good about things. In February of 2019, the family went on vacation down to Florida. We came back, it was the last week of February, we came back early March, kids go back to school, we all go back to work. And everybody had like sore throats and everybody was sick and we all had swollen glands. But about 2 weeks after that, everybody else's glands got better and I had one lump that popped up right there. And it wasn't going away. And I had a doctor's appointment coming up for my routine physical. So I just waited another week and I went to see him and I said, what's that? What do you think? And he said, ooh, I don't know what that is. Why don't you go to these ENT? And he sent me to the ENT. So about a week and a half later, I got my ENT appointment and I went into the ENT and he said, I don't like that. Did the biopsy in the office, said, I'll see you in about a week, week and a half. And it was 2 days later, he called me and said, hey, I need you to come in. We need to talk about something. So I figured that was probably not good. He was able to connect me with the folks at Head and Neck Institute and to deal with the cancer. Diagnosis of cancer came in that lymph node indeed had cancer. I went in, met with the docs there, and indeed it was an HPV related cancer on the tonsil, a little bit on the tongue, a little bit on the roof of the mouth. I was terrified. I remember coming home and like lying down in the bed, going to my kids' room and saying out loud to nobody that I failed them. I prayed, I talked to people, I listened to my doctors, I stayed positive, kept looking for a way to conquer each day by staying positive, staying active. I walked, I directed a play during my radiation treatments. I built the set by myself because I needed something to take my mind off it all. I talked to family, my church group, everybody. I mean, all of it helps. It is brutal. It's just, treatment is brutal. The cancer diagnosis is brutal. It's bad. You put up a front because you want to stay positive, and positivity breeds positive. And then more people are rooting for you, and that's fantastic, but it is exhausting. So I went from somebody who used to grouse about the inconvenience of going to the doctor 5 and 6 times a year. I had over 180 days of some kind of medical appointment over a 16-month period. 180 days, a half a year spent in the company of medical folks who were there to take care of me. That's wonderful, but not the way I wanted to spend those 180 days. Diagnosis, I had 3 surgical procedures. I had a lovely little cut from here to here that was 7.5 inches, glorious looking, healed up nicely. My daughter was the one who measured it. I had the TORS procedure, the robotic surgery, where they went down the throat and they were able to get the cancer out. It was fantastic. I recovered to that. I only had 3 nights in the hospital from those 2 procedures. I had 30 rounds of radiation. I had 30 rounds of hyperbaric chamber treatments because a piece of my hyoid bone splintered off from the radiation and poked through the esophagus. So that led to the procedure, but that was a day in and out procedure the same day. It was tough. And I went from somebody who was really, really boring to somebody who became way too interesting to our medical professionals out there. I went from from weighing 215 pounds to 165 pounds. I was really sick, and the treatment tremendously successful. And for that, I'm very thankful to all the doctors, all the PAs, all the nurses, all the administrative folks who supported, took care of me, took care of my family. My last PET scan was just a couple of weeks ago, no sign of recurrence. I'm healing. I'm back up to about 185 pounds. My energy level continues to improve. But, I was very fortunate because I was able to keep working. I'm in sales and I travel and I could limit that to, I work from home. My company and my boss were extremely accommodating, but I think about all the people who can't do that. You guys can't. You can't patients as a medical provider without being in contact with them. So how do you do your job or plus in hospitality or line work on a factory or construction, agricultural? You can't do what I've been fortunate enough to do, which was continue to work, had good health care, insurance and all things. The emotional weight gets to be so much more complicated when it's faced with income struggles, being on short-term or long-term disability. How am I going to pay my bills? How do I take care of my family? That's a really tall order. And it's something that we don't have to face with this particular type of cancer that's HPV related. So we can vaccinate our kids. We can protect them from HPV and HPV related cancers. I have two teenagers. I have a boy and a girl, and both Kirk and Isabel were vaccinated before I was diagnosed with HPV. They are 17 and 18. I probably contracted HPV in college in the 80s. We were all freaked out about HIV. We didn't even know what HPV was. I never knew I had it. I didn't have any symptoms. So I think about what our kids don't have to deal with if we can vaccinate. So we can vaccinate our kids. We can prevent the pain, the disruption in life, the fear that comes with cancers associated with HPV. Everybody I talk to, I'm very upfront with my diagnosis, and I tell them that it was cancer, it's a throat cancer that was from HPV, a virus that can be prevented. And then I'll ask them if they have kids, if they've been vaccinated. I have friends, when I shared this with other friends, I have now found 3 that I know personally who have had a cancer related to HPV that I did not know about before. I knew they had cancer, but they hadn't shared that it was HPV. So whatever people think about the downside of vaccinating is, it doesn't compare the brutality of a cancer diagnosis and going through that treatment, the disruption that it brings and the fear in your life. So thank you for today. Thank you for doing everything you can to help prevent these types of cancer. I know that I'm going to continue to evangelize about it. I know my kids are telling their friends about it, story openly. So thanks for having me to share my thoughts. Feel free to share my story anytime. HPV can be prevented, so let's prevent it. Thank you.
Thank you so very much, Kevin. I appreciate you, and we appreciate you for coming and sharing your story. And it's very important for us to remember that, you know, when we talk about vaccines and vaccinating and data and numbers, that oftentimes we forget the individuals behind those numbers. So thank you, Kevin, for coming and sharing your story with us today. So we want to thank you all for being a part of our series for the HPV vaccinations getting back on track here in Georgia. Thank you for sharing with others to get them to participate. We did want to let you know that we will have a touch point in 2021. We're going to send out an email with a quick survey to learn more about how you felt about these webinar series, and if there are other topics that you would like us to cover as the HPV work group in the coming months. We want to extend, again, a special thank you to all those who helped make this possible. These webinars didn't just magically come together. It took a lot of work and background activity. We want to thank our speakers who were willing to take time out of their busy schedules to present. We want to extend a special thank you to Amabwache, who has been phenomenal behind the scenes making things happen. We want to thank the Georgia chapter of the American Academy of Pediatrics, who partnered with us to allow us to get the CE credits for our webinar series this year, and then the National Roundtable as well. Another special shout out to all of our partners. And again, as a reminder, if you want to receive your CE credits, make sure you complete your evaluation, and we'll make sure to put that evaluation in the chat box. You will also receive it via email and at the end of today's presentation. If you're interested in joining our HPV work group, we are always looking for additional partners who want to join us in this work. It's very important work, and we would love to have you join us if you would like. We also wanted to share a quick resource about HPV in men. There is a fact sheet. Again, that link will also be put into the chat box for you. As Kevin made it very clear for us this morning and this afternoon, that HPV isn't just about women and cancers that impact women, that it impacts young men as well. We also wanted to make you aware of this resource. It's the Cancer Prevention Through HPV Vaccination. It's a guidebook for physicians, physician assistants, and nurse practitioners. So it'd be a wonderful opportunity to take a look at that and see what types of tools that you can utilize to increase your HPV vaccination rates in your office and your clinic. Thank you all so very much for taking time out of your morning to be with us today. We appreciate you participating with us, and we ask that you complete your survey and let us know what you think once we send out that follow-up survey in 2021. Thank you all so much, and you all have a wonderful rest of your day.